My patient is a 4-year-old male child from Tiruvallur, Tamil Nadu, whose informant was his mother, had come with complaints of fusion of ring and little fingers of both the hands since birth. So he also have a history of DV.
The screen is gone.
Yeah.
He also have a history of deviation of fingers and no history of fusion of toes and no history of other congenital maladies, and there is no history of previous surgeries or noted. So his parents are non-consanguineous marriage. He was a firstborn child and full-term normal virginity. His mother is also have a history of syndactyly in right ring and little finger for which she was treated. So this is a clinical picture showing that syndactyly involving both right and left hand of ring and little fingers. So general examination, the child is alert, active. There is a mild anti-fungal sign of eyes first. And coming to systemic examination, other than that, there is no congenital signs of congenital anomaly. Coming to cardiovascular system, normal. Respiratory systems are normal. Abdomen and system points are found to be normal. So examination on inspection, there was a fusion of right, both ring and little fingers of both the hands extending from web space up to the tip of the fingers was noted, with the fused nails with the ridges was noted. There was angular deformity of the ring finger was noted, and then digital crease which was well developed at MCPJ and PAPJ joint, and there was a fine crease was noted at the PAPJ joint. Range of movement, active range of movements was full at MCPJ and PAPJ joint of fingers, and there was a restricted at the distal interphalangeal joint, and passive range of movements was full at all the joints. Distal sensation was intact, distal vascularity was intact. So examination of forearm, arm and chest was found to be normal, and there was no syndactyly of toes noted. So X-ray, I have taken X-ray which shows a fusion of distal phalanx of the ring and little fingers of both the hands. So X-ray showing the fusion of the distal phalanx.
Can you zoom that terminal phalanx? So where is the little finger middle phalanx? Show the other hand. Zoom that. All three bones are there.
Hypoplastic, sir.
Hypoplastic. What is hypoplastic?
Probably missing or hypoplastic.
Missing. Probably missing.
And zoom some more. Zoom it fully. Especially when you are coming for a presentation, you got to be, the clarity must be there. Everybody must see that. Zoom.
That's all I know.
So ring finger, all three bones are there. Little finger?
Yes, sir. Little finger, there is absent.
What is absent?
The mid phalanx.
Middle phalanx is absent.
Middle phalanx.
And terminal phalanx?
There is a present, sir. There's a distal fusion is there.
Like fusion. Sometimes you can have an overlap. It will look like a fusion. You have to clearly see whether it is fused or not.
Okay.
Dr. Karthik, what will give you a good tip about the fusion in clinical exam?
Mukund, I think you can repeat the question.
Dr. Karthik, what will give you a good tip about the
sir.
fusion in the clinical exam?
When you presented the clinical
There is a fusion.
when you
Dr.
presented the clinical features, you mentioned something that suggested that fusion of the bones is there. What is
Yes,
it that you mentioned?
And the nails are fused, and there is
Ah.
the crease. The crease is very faint in that in both the CAP joint, and it's well developed, and in the DAP joint it's very faint, sir.
Fusion of the nail.
Yes, sir.
So for all the PGs over here, the nail is a window on the bone. If there is no nail, there is no bone. And if there is a nail, there is always a bone. And then depends on how the two nails are, the underlying bones are like that. So the nail is a very good window on the bone.
Proceed.
So my diagnosis will be bilateral congenital complete complex syndactyly of ring and little finger in a 4-year-old male child.
So how will you account for the missing middle phalanx?
Since the child is a 4-year-old male child, and due to syndactyly involving the ring and little finger, there can be a growth, arrest of growth will be there in the border digit.
No. There is no arrest of growth.
Okay, you have mentioned that it is a congenital complete complex syndactyly. Now, syndactyly, as you know, sometimes is associated with syndromes. Could this be associated with any syndrome? What all have you ruled out?
Sir, syndromes we should associate with common syndromes of Poland syndrome and Apert syndrome, and constriction ring syndromes are usually commonly associated with syndactyly. So for Poland syndrome, I will examine for the chest wall, and then upper limb, entire upper limb, and then for breast hypoplasia, I will see in the female patient.
Dr. Karthik, your volume is very low. Can you increase your volume, please? Can't hear you properly.
Go slow, go slow. Be very deliberate and go slow. Speak to your mic.
Yes. And then there will be in Poland syndrome, there will be syndactyly of the central digits will be involved in Poland syndrome. In Apert syndrome, there will be a craniofacial anomaly due to synostosis. There will be hypertelorism and bulging of eyes, and hypoplasia will be there noted. Maxilla will be noted, and with this there will be a syndactyly of the fingers will be noted in the Apert syndrome. Inconsistent ring syndrome, it occurs due to it occurs, there will be a simple consistent ring, and the second time there will be consistent ring with the deformity of the fingers, and then third time there will be a consistent ring with the syndactyly will be noted, and the fourth there will be amputation of the fingers are noted.
Name all the varieties of syndactyly. All the varieties.
Sir, syndactyly will be there will be a simple, complex, or complete complicated syndactyly, which may involve both complete or incomplete in simple, and the syndactyly may be associated with syndrome, or they can be isolated, they can be presented as isolated, or they can be associated with upper limb deformities, including cleft hand, and we can present as syndrome.
You have said congenital. First word was congenital. So is there any other type of syndactyly?
Surgical syndactyly, where we are creating for a trauma case, we will be giving a syndactyly, which requires groin flap and everything.
Yes.
Then we have to divide, so that comes under surgical syndactyly.
Yes. Then anything else? PC following a condition.
Burns.
Burn.
Have you seen?
Yes, sir.
Then why you did?
Okay, then you said you went off very fast about the different types of syndactyly. Congenital, you have said the other types. You have said complete. Why did you say this is a complete syndactyly?
It extends from the web space up to the tip of the finger. So I say it's a complete syndactyly.
What is the other type?
It's an incomplete, which may extend from the web space, but it does not involve the tip of the fingers. Before the tip of the fingers, it can.
Yeah. So why did you say it's a complex syndactyly?
Sir, its involvement of the bony fusion was there in the mainly involving the distal phalanx. So I committed as a complex syndactyly.
Okay. Is there any other type of syndactyly?
So in complicated syndactyly, there will be abnormalities of the bone within the fused digit. It can be either duplication or where a bizarre arrangement of the digit bone will be seen there. So it comes under complicated syndactyly.
Okay, good.
What is brachydactyly
Brachydactyly,
or brachysyndactyly?
usually the digits will be very short and there will be a fusion of the digits. Is brachysyndactyly.
What will be absent in the short digits?
Usually the middle phalanx will be absent in that. So it comes brachysyndactyly will be there.
So here there is an absence of middle phalanx.
Yes. In the little finger,
Ah,
there.
so can you call this brachysyndactyly or symbrachydactyly?
Yes, sir.
Pardon?
But there is no shortening.
There is no shortening of little finger. Huh?
Yeah, as we can call in that. You can call it a symbrachydactyly.
I would like to call it as a complicated syndactyly rather than a symbrachydactyly or a brachydactyly. What, Mukund?
Yes, agreed.
Yes, yeah, as he himself mentioned that when a complicated syndactyly is when you have other problems associated with it. So obviously here, because the absence of the middle phalanx, there is obviously some element of brachydactyly also. And you cannot say it's not short because if one phalanx is not there, obviously the finger is short. Okay. So it is a complicated. You can add that word complicated to this, your diagnosis. You should have added, it would have given a better feel.
Okay.
And second thing, what will be the problem? Suppose the patient comes to you at the age of 3 months or 6 months,
Okay.
or 6 months, you say. You would have done a syndactyly release at that time, or you would have waited for 4 years for the child to grow. What could have happened in this waiting period? Especially in this kind of.
There will be sir, this has involved border digits. So you have to release at the earlier stage to prevent the growth deformities of the involved fingers. So I would undergo surgery in the early years.
More so when already there is a further shortening because of the absence of middle phalanx. So there is a gross disparity in the length. So you allow it to grow like that, the deformity of the ring finger is difficult to correct.
Yes.
Okay, there will be always a curvature towards the little finger. Okay.
Yes.
And you're going to have a scar along the ulnar border of the little finger, ring finger. That will also produce some curvature. Scar contraction and curvature. Okay.
Yes.
Okay. So diagnosis, we all agree that it is a congenital, complicated, complete can be there, complicated syndactyly. Okay.
Yes.
Next.
Investigation. I will do a routine investigation, blood investigation, chest X-ray, ECG for anesthesia assessment, and I will coordinate with our pediatrician and cardiologist to rule out any other congenital anomalies, and then I will plan for the patient for surgery. So before planning, I will give a pre-surgical counseling for the patient attenders, and then I will plan for a surgical syndactyly. My pre-surgical counseling involves about the patient's need for surgery and the timing and the time needed for anesthesia, and then the post-op need for a follow-up, and further for post-op follow-ups are explained, and then I will plan for a surgical syndactyl release. Sorry, the syndactyl release.
One more thing you need to mention when you're talking to the parents, because you are going to release the syndactyly, assume, and are you going to harvest any graft from somewhere?
Yes, sir. I will
So
harvest
will you mention that?
Huh?
Huh?
I will inform them. I will clearly explain them, sir.
Yes, because it's very important. You can't send the patient telling the patient they're going to operate on the hand and come out with another dressing on the groin region or something. It will be alarming for the parents. Yeah. Yes. Please go ahead.
I am planning for a surgical syndactyl release as described by Boy's technique, sir. This is my
Dr.
incision
Karthik,
for the,
sorry to interrupt you. You are planning to do both at the same time? Both
yes,
hands?
sir. Yes, sir. If I will discuss with the parents. If they are able to take care of this child, and then I will simultaneously proceed with the bilateral hand release, sir. Since they are coming from, yes, sir. Since they are coming from far away place, and they will be definitely they will not. I suspect they will, whether they will come for other release, I will suspect. So I want to release at the same time.
Okay.
Okay. Before you go into the surgical aspects, what are the principles of syndactyly release?
Sir, only following are the principles of syndactyly release. The one side of the digit should be released at a time, and then the dorsal flap for the commissure should be from the local flap, and then for the lateral side of the finger, it should be given with a zigzag triangular flap, and finger, and the raw area should be covered with full FTLG graft, and then if possible, there is skeletal deformities, they can be corrected. You should use the absorbable sutures, and then adequate dressings and padding should be given. Patient should be regular follow-up.
Okay, please go ahead.
Karthik,
Yes, sir.
we are seeing the markings.
Yes, sir.
And whose name is this technique is?
Boy's technique, sir. B-A-U-E-R. Boy's technique, sir. B-A-U-E-R.
So,
Okay, how did you make the markings? On what basis?
Sir, if you have, I will mark the metacarpopharyngeal joint and PAP joint, and will mark the mid-dorsal plane, and then for a dorsal flap, I will mark from the metacarpal hand up to the 2/3 of the proximal phalanx, and then I will mark the zigzag incision based upon the long finger, and then I will extend up to the DAPJ, and then I will extend up in a straight line. For the volar, I will plan for a palm or rectangular flap based on the ring finger, and then the mirror image of the zigzag incision was made over the volar side in the rest of the finger. And for the nail, I will plan for a lateral triangle flap described by the background code.
Okay. Yes.
Few questions, Karthik. Dorsal flap.
Yes, sir.
The dorsal flap, the distal edge, it is going to be transverse, or you want to make it slightly slanting?
So I want slightly slanting, sir, so that I have a sloping for the dorsal that will be created.
No, that will not give the slope. That will only widen the first base of the first triangular flap. You see all your triangular flaps, there are roughly 2.5 flaps, am I correct?
Yes, sir.
The first flap, which is based on the little finger,
Yes, sir.
it has got a narrow base.
Okay.
If you want a wider base, you have to slope it.
Okay.
Okay.
Yes.
So, but still it can be, people take very narrow flaps also. So it can be taken also. That is not my question is whether you want to make it slopey or you want to make it like a pure rectangle flap.
I want to make slopey, sir.
What is the normal shape of the finger web?
Sir, it's a hourglass shape with 45-degree angulation from dorsal to palmar, which extends from the metacarpal phalangeal joint up to the middle phalanx, up to the middle of the proximal phalanx.
Yes, good. Yes. So you mark the flaps, and I assume you're going to raise the tunicae now. You're using a tunicae. What pressure will you use for the tunicae?
Sir, usually about 80 to 100 above the systolic pressure will be kept, sir.
Okay.
So I will first make incision for the dorsal flap, sir, and then I will raise the dorsal flap along with the dorsal venous system, preserving the dorsal venous system, and then I will make a dorsal zigzag incision, and then I proceed towards the volar surface, raising the palm of palmar rectangular flap for the figure, and then I will make the incision for the zigzag incision over the volar aspect of the volar aspect, and then I will give a and I will start from the dividing the finger from the distal to proximal base until I will go proceed up to the bifurcation of the neurovascular bundle, extending the facial bands in between the fingers, and I will release the.
You said bifurcation of the neurovascular bundle. When you're separating the two fingers, which will you encounter first, the nerve or the vessel?
You will require the nerve will be encountered.
Are you sure?
You will bifurcate from dorsum or volar? That is the question, Karthik.
Vessels will be first will encounter. Then
sorry, I can't hear you, Karthik.
Yeah, your voice is very muffled.
First I will encounter the vessels in the
Vessel.
Okay.
No, I think what Dr. GK wants to know is where is the nerve, where is the vessel? Dorso-volar.
No, I think Karthikeyan wants what level bifurcation.
Yeah, I wanted to know
whether
dividing between the two fingers, which is he going to encounter first, the vessel or the nerve? So, for instance, you said you're going to encounter the vessel first. So, obviously, you can't go beyond that. Or are you going to ligate the vessel and go distally? Are you going to ligate the vessel now, divide the vessel now?
Sir,
you're going to stop at the bifurcation, isn't it?
I guess so.
Yes. Okay. Okay. Now, another question. This dorsal flap that you have marked, what is the shape of this flap?
It is a rectangular.
Rectangular flap.
Rectangular
is it an axial pattern flap or a random pattern flap?
Random pattern flap.
What is the dimensions of a random pattern flap?
So, 1:1.
Now, here you seem to have, you said it's rectangular. That means it's more than 1:1. Is that okay? So you should have asked this question earlier when somebody explained this to you, when they explained markings. No, this is actually, it's an axial pattern flap because you've got the dorsal metacarpal artery perforators coming in here. So it's actually an axial pattern flap. That's why it's allowed to be taken as a rectangular flap, right?
Okay.
Please go ahead. So you've divided the fingers and you've raised all the flaps and divided the fingers. Yes.
Again, Karthik, you said the palmar drawings is a mirror image.
Yes, sir.
Is it a mirror image?
What exactly in the dorsal side, we have to match the same as the wall.
Then how can it be mirror image?
It's the same.
You understand my question?
Yes. Yes, sir.
Mirror image means it has to be ulta.
Ulta, yes, sir.
It should not be like that. What you see on the dorsum, the same thing you have to draw it on the palm. Okay?
Yes, sir.
Okay. Go ahead.
Sir, We have just one small interruption, sir.
Yeah.
We have reached the 25 minutes mark, but
Okay.
the questioning is going on so beautifully, and he is also defending it quite well. I think we can continue maybe for another 5 or maximum 10 minutes, sir.
Yeah.
5 minutes.
5
Wow.
minutes, yeah.
So, Karthik, sometimes people actually do take mirror image because they want opposing flaps to cover one finger better than the others. Then you know, for example, if you see your dorsum, your somebody's talking.
Somebody is talking.
So the flaps have to be exactly reversed
Yes.
so that the two opposing flaps come and cover the finger. Okay, never mind. Just one last point. There are some authors who believe that the tip of the rectangular flap has to be concave. And they believe that by making it concave, the web creep is less. Whether true or false, I don't know.
Yeah, but Alan Gilbey makes it apex.
That is another, yeah.
Yeah. And this is
In
this
fact,
mark.
the fact that there are so many methods of these flaps shows that none is satisfactory.
And to me, I thought this is Adrian Flat's marking.
Adrian Flat.
Adrian Flat's marking.
Yeah.
And when you're doing simultaneously both hands, so two team of
Tell
both,
me.
why somebody is disturbing. Will you do simultaneously? Karthik?
You're asking me or him?
Karthik.
Karthik.
I think he has left.
Karthik is missing. Dr. Karthik?
Okay, then we'll finish this.
Dr. Karthik's, I think connection has gone off.
Something wrong. Okay, we'll finish that.
Okay.
So
I
the
think
only
before we
other
go,
thing-
we should only discuss the fact that generally people prefer FTSG to SSG.
Yeah.
That's the only thing. And the tip about FTSG is to take it from the lateral half of the groin crease because otherwise in future hair might grow on it.
Yeah, that's
Yes,
an
sir.
important point.
Karthik has come back.
Yes, sir.
Karthik, you got fed up with us and ran away or what?
No, sir, some technical issues there.
So now we can hear you better also, Karthik.
Yes, sir.
Okay, now you have done the surgery and you're going to put a graft, isn't it, for the
Yes,
royal?
sir. Yes, sir.
Where are you going to harvest the graft from?
From inguinal crease, I will usually go.
Yes.
Other sides maybe, it may be from the lower aspect of the wrist and the middle aspect of the arm.
Sandeep, somebody is.
It's some 1 plus LE to 111.
We'll just get it this one, sir. We'll just mute that, sir.
Even the video also.
I think except the three of
Dr.
us and
Rohit, can you
Karthik.
just mute the Dr. Rohit, can you just mute the people, no?
Sir, actually right
Yeah,
now.
the one.
Okay, sir. I will do.
Go ahead,
Dr.
Karthik.
Karthik. Yeah,
Yes,
go
sir.
ahead, please.
No, they were asking. Karthik.
Yes, sir. Yes, sir.
Okay, you have harvested the full thickness graft, you have sutured everything, isn't
Yes,
it?
sir. Yes, sir.
What dressings, how are you going to apply dressings for that? How are you going to immobilize? If you're
Yeah.
going to immobilize.
I will give a single layer of Vaseline gas, and then I will give an adequate padding between the fingers, and then I will immobilize in the dorsal hand POP, and then I will check the dressings at the 10th POD, and if needed, you
Okay,
can
what POP are you going to give?
dorsal hand POP, sir.
Below elbow, above elbow?
Above elbow.
Ah, yes. Why above elbow?
Usually these childs are very difficult to manage. It will come and it will easily come up. So I want to give a flexion at the elbow. So I will go for a dorsal and POP, sir.
Okay.
Karthik,
Yes, sir.
you said we will do it under tourniquet.
Yes.
When will you release the tourniquet?
Usually we will release before giving insert on the flaps insert. We will release the fire and then we will fix it.
We'll release and then after that achieve
I will give
hemostasis and then
and then sutures.
suture it.
Yes, sir.
Why?
Because I will be seeing dressings will be on the 10th day only, sir. Then furthermore, I have to keep an FDSG and then flaps.
Why do you want to release the tourniquet and then suturing? I will suture it first and then release the tourniquet.
Sir, I want to
And
know.
for the raw area grafting, probably after releasing the tourniquet, I'll apply the graft.
I want to verify. I want to achieve the hemostasis, sir. So I will verify.
Suppose the finger swells
Fingers
up.
first.
The finger swells up. Immediately after releasing the tourniquet, the finger swells up. What you could have sutured, now it becomes difficult.
Yes, sir.
So normally you release the tourniquet, achieve hemostasis, and then suture, or how do you do it? Or how you have seen it?
So we will release and then we will suture it.
And my question is, simultaneously will you do it?
We will do both the hands at the same time.
Both times simultaneously you will inflate the tourniquet?
No, sir. First, I have to release one hand and then I will go after releasing and then I will proceed to the next.
Okay, now Karthik.
Yeah, how long is your immobilization and what is your protocol post-operatively?
So I will check the. We will check the dressings at the 10th post-operative day. On the day, if this okay, we will remove the POP and for advice for a mobilization, and then we will advise for a regular wash, and then mobilize active and passive mobilization. We will ask the patient to take.
So you will expose the graft without dressing on day 10.
Usually, we will check at the 10th days or after.
Yeah, but full thickness grafts in 10 days are not always well settled. Well, anyway, there are differences in institutions, but I wait for 20 days, 3 weeks, before I let the child free and do whatever the child wants. Because once you let the child free, they are uncontrollable.
All the wounds should heal.
Yes.
So the graft takes about 3 weeks before you can be happy about the child fingering that graft.
Okay.
The child is going to finger the graft 100%. Okay, never mind. One last question.
Yes, sir.
What is there some inheritance in syndactyly?
Yes, sir. About 30 to 40% are inherited, sir. This is due to autosomal dominant.
Okay.
So with the variable penetrance, so there is inheritance is possible in the child.
So the correct word is variable penetrance.
Penetrance.
Yeah. Good.
Okay.
Okay, I think Sandeep.
Yes, it was an awesome presentation, sir. So just one question to all three of you, sir. All of you would be doing, I mean, is there, so we saw how Karthik has actually presented this particular thing. Is there some difference in design for any of you, sir?
So, you know what, Sandeep, I personally think that we should not quibble over designs. Everybody has different designs. As long as basic principles are followed and something is done to create a web space, there's not much point fighting over the design. Nothing has been proven to be the best. That's what I think.
That's why we have so many designs.
Yeah.
Not one is the best.
Late Dr. Dias used to say to me, Mukund, if there are 15 operations for one condition, that means none is satisfactory.
Okay, sir. And regarding immobilization also, just one question, sir. Regarding some centers, I think they are using KYS to actually immobilize the fingers and extension. Is that like that? No.
I never do. I used to do when I was a very young man and then release the tourniquet and see the finger was white. So I stopped doing that long ago. We should allow the vessel to take its own position and not go into spasm.
Okay. The third question that I had was regarding the immobilization. Would you actually, because in certain centers, they are actually putting a cast rather than a slab, a very loose cast, but always extending up to the axilla, from the hand to the axilla. Would you prefer to do that or would you prefer to put a slab?
GK, what do you?
I always put only a slab. I don't put a cast. Okay. I somehow feel it's more comfortable for the child also for putting a slab alone. I've never put a cast so far. I use a cast only for replantation of the extremities, but not for syndactyly release.
I don't use plaster at all, Sandeep.
Oh,
I do an enormous padded dressing all the way to axilla. I don't see what the plaster is doing for this case.
No,
I don't put
to
any
keep
plaster.
the hand elevated, we put a
Yeah, so with a big
90
padded dressing, we can still. Yeah, so as I said, there are slight.
yes,
In
yes.
Sanskrit, it's called pat bhed.
Yeah.
Yes.
And I think best is to perfect one technique
Yes.
and see to that future line heals well, graft takes well, 100%.
Correct. Correct.
And I have seen one dreaded complication, of course, not done by us. Partial finger loss also can happen.
Oh, yes. Oh, yes.
Okay, you got to be very, very careful about, especially when you're ligating vessel on one side, you got to be careful. So perfect one technique and try to master it. And we follow Alan Gilbey, that anchor visor technique.
Yeah.
On the volar side, there will be a anchor like, and the dorsal flap will be like a hourglass. So that gives a nice thing. Whatever it is, we always, Niranjan, I don't know how Niranjan from UK, we always, simple syndactyly, he closes primarily, all, without a graft. But we were not able to achieve any of all, we always add grafts liberally.
Yeah. Well, Ramesh Sharma has written a paper on it.
And
The syndactyly without graft in PRS 2009, I think.
Contact surface, try to close it primarily.
Yeah.
You can do some cheating.
Not
For
only
example,
that, these people who say they won't use a graft, they do very, very aggressive defatting, especially in baby fingers. Therefore, the size of the flap becomes bigger than the defect then.
I am against defatting.
Yeah.
Because the finger shape itself becomes a little skinny.
Yeah. Yeah.
And the pliability of the skin will not be good. So I am against the defatting. They put sutures, leave loose raw areas here and there. Maybe there the scarring is not that bad, but our people, if there is no primary wound healing, the scarring is very bad.
Yes. Karthik, finally, is there something long-term you do for preventing web creep?
I will really follow up the patients and I will give a scar massage and the physiotherapy. And then if there is any raw area addressing, I will.
What physiotherapy are you talking about? Scar massage? Yes. What physiotherapy?
Sir, really active motion, range of movement and passive
motion is not their problem. The web creep is the problem.
Yes, sir.
So how will you prevent that? Anything else you can do?
We will ask the patient to keep elastic padding in the sufficient padding will be there. Sir.
Padding of some particular material?
Elastic padding.
See, if you want to seriously deal with it, then silicone spacers should be put to retain the shape.
Yes.
But it's very difficult to retain in the child. If the child is retaining, then it's okay. If the child is removing every 5 minutes, then